Good evening, everybody. Thank you for all being here today. It's my pleasure to welcome you to our lecture session today, where we have the honor of hearing from our truly amazing orthopedic physician, Dr. Politzer. Dr. Politzer is a respected physician with a strong track record improving painful joints. Today, he'll be sharing his insights regarding knee pain. A few housekeeping items. We'll be recording today's session. For those who couldn't join us live, there will be time for Q&A at the end, so please hold your questions until then. Please utilize the chat at the bottom. If your questions weren't answered, please schedule an appointment with Dr. Politzer. We'll be sending out all of this information for today's session after. So without further ado, please join me in welcoming Dr. Politzer.
Thank you so much, Myrna, and thank you so much, everyone, for being here. I'm excited to talk to you tonight about knee pain. I'm going to bring up my slide presentation for you now. Okay. So we all good, Myrna? All right. So again, I'm Carey Politzer. Happy to be here discussing knee pain with you. Joined Ortho back in September, and it's been a fantastic time so far. Just a few housekeeping items that Myrna already went over, but just to verify for people who just joined us. Again, thank you. You are muted during the presentation, but you will have the chance to ask questions in the Q&A like throughout the talk. And at the end, I'll go over some questions that I see. And if you have, if I don't, those questions don't get answered, please feel free to come and make an appointment with me or one of my fantastic partners. The presentation is recording and will be put up online for later viewing as well. And I have my follow-up email here. It'll also be at the end. You'll be able to write that down or to contact me to either ask any additional questions or make an appointment. So let's get started. I am Carey Politzer. A little bit about my background. I was born and raised in Wyoming, PA. Go Spartans. I went to Duke for undergrad, and I majored in neuroscience there. And then I went to the Duke School of Medicine after that. I spent my residency in San Diego at UCSD. Very, very beautiful place to do training. And saw a lot of very diverse types of orthopedic issues, especially orthopedic trauma, and that also really ignited my passion for hip and knee replacement, which is why I did a fellowship in hip and knee replacement surgery at UCSF. And that was also just a wonderful additional training to really hone my skills and continue to really reach my passions. So now I'm landed at Ortho Bethesda. I have clinic both in Bethesda and in Tysons, part of the Washington Joint Institute, and it's under the umbrella of Aligned Orthopedic Partners. So today we're going to talk about your knee. The first part of the talk is about why the knee or how it works and why it hurts. The second part of the talk is going to go more into treatments. For this talk is mainly geared toward patients who are over the age of about 40. And so it is going to be more kind of talking about the degenerative side of the knee. If that doesn't include you, please, stay on and, maybe you'll learn something anyway, but just to give you a heads up. So the knee is comprised of four different bones. It's three bones, the femur, the tibia, and the patella. It's the largest hinge joint in the body, so it mainly does flexion and extension. But as you may have noticed, if you plant your foot and turn, it also has some rotational and translational motion as well. And so that makes it a more complex joint than just a simple hinge, which is why it takes all those years of training to figure it out. The tissues in the knee include bone, cartilage, meniscus, ligaments, and muscles and tendons. And the cartilage is the smooth surface of the bone that allows it to glide and uh, and that's the surface that can get degenerated in degenerative conditions like arthritis. So there's tons of causes of knee pain, and we're not going to go over them all today. That's kind of what I was kind of getting at. But it could be arthritis. So our osteoarthritis is the most common type, and this is due to the wear and tear on the cushion and the joints. It is a degenerative condition, so it won't get better. It might get worse. You know, you can kind of have some roller coaster flare-ups and and times of calm, but in general, the gradual trajectory is a little bit worse and worse. And we don't have any medications at this point that can alter the osteoarthritis process. I think of arthritis kind of like the treads on a tire, and you know, I also kind of fancy myself as a kind of a mechanic. But the treads on the tire, as they wear down, ultimately they get bald, and when the bald part of the tire starts hitting the road, that's where, like in the knee, when the cartilage starts wearing down until it's bone-on-bone arthritis. In another type of arthritis is rheumatoid arthritis, and that one is an autoimmune disease. It's much less common than arthritis, but important to understand a little bit of the nuances and differences. This one attacks the lining of multiple joints, and that can cause swelling, pain, and deformity in the knees, and you know, other joints, including the hands. And there are disease-modifying medications for rheumatoid arthritis. So in you know a lot of people who may have had very, very severe deformities in the past on these anti-rheumatoid medications can hopefully save their cartilage. But you know, sometimes the disease is so severe that us as surgeons still have to intervene. So if you think you might have rheumatoid arthritis, you can talk to your PCP about a rheumatology referral because the medical treatment is going to be extremely important. But in terms of osteoarthritis, that's where my specialty and uh, passion lies. So the symptoms of arthritis are mainly chronic knee pain, stiffness, deformity. So you may notice that the knee is becoming more and more knock-kneed or more and more bow-legged. There's swelling and inflammation in the knee, and so it might swell up by the end of the day if you're walking a long distance. Hurts on stairs, hurts on when getting up out of a chair. And then there's difficulty with those everyday activities. And so, like I described before, arthritis can be just kind of a disease where it gradually gets worse and worse. But oftentimes it is flare-ups interrupted by periods of relief. Sorry, I think I cut out a second. So arthritis does cause, so why does arthritis cause knee pain? So in a healthy knee, like I said, the end of the bone is covered in cartilage, whereas in the arthritic knee, this wear and tear and degeneration can lead to increased friction among the bone, between the bones, friction between the bone and the meniscus, and the meniscus is the cushion in the knee that also gives it some stability. And so that can cause meniscus tears, that can cause various other types of inflammation. And as that arthritis gets worse and worse and cartilage gets, you know, more and more degenerated and sheared off, it can cause ultimately bone-on-bone contact, and that can be very, very painful. The most common form of arthritis, again, is wear and tear. This example on the right shows what the cartilage appears at the end of the bone with joint fluid in between, and the meniscus is the yellow part in the front and back. And so these joint changes can be irreversible, and it often does go undiagnosed until the disease has progressed at least to the kind of mild to moderate stage, at which point we can intervene. The as this joint joint as arthritis progresses, the pieces of bone and cartilage can break off and float around in the joint and can, like I said, cause meniscus fraying and tearing, and therefore, as the meniscus starts to degenerate, the whole part the knee can become less stable. There's no longer something holding it together, and so that's where the instability can start and the feeling of maybe the knee giving out on you. And there can be bone spurs that start to grow as well that can catch ligaments in the area and just as a sign to me that this arthritis has been going on for a while. So this is an example of an X-ray with mild arthritis of the knee. The joint space is slightly decreased compared to normal. But overall, there's no major bone spurs. There is a good amount of space, and overall, and the alignment is still neutral. Okay, so this is a very, mildly arthritic knee. This is as the disease progresses, you see the joint space start to get smaller and smaller as the cartilage gets worn down. Maybe there are some meniscus tears. We can't see that on the X-ray, but that's what I would expect here. And then the sides of the joint start to kind of the shape of the size of the joint starts to change, and you start to get some cornering of the joint on either side, and that ultimately turns into bone spurs. And finally, this is the severe version of arthritis. Now it's much more bow-legged than it was before, and the bones are bone on the cartilage is gone on the inside of the knee or the medial side, and so the space is now gone, and we call that bone on bone because the bone is rubbing on the bone in that picture. So there are several risk factors of arthritis, and so we don't fully understand why arthritis occurs, but we know certain things that can predispose people and make it more likely that they will get arthritis. There are certain things that we can kind of change, and there are certain things we can't. And so arthritis is associated with increased age, although it is not, I would say, a normal part of aging. It is a disease process. It's also associated with genetics. If it runs in the family, certain people have, parents or grandparents or siblings who've gotten knee replacements at a younger age, and that does make you more likely to develop arthritis at a younger age as well. Prior injuries can lead to arthritis because of the damage to the cartilage at the time of the injury, and that's whether or not you underwent meniscus repair or partial meniscus work at the time, or like an ACL reconstruction or something to that effect. And finally, instability in the knee can also irritate the cartilage and cause more inflammation and potentially more damage to the knee, which can accelerate that inflammatory and arthritic process. I did want to just touch on the one of these processes that is more potentially controllable for many people. So the weight is the factor that we do see a lot of arthritis in more overweight, obese, and morbidly obese people. And now obesity is becoming much more common, and arthritis is also becoming much more common in those patients. And so maintaining a healthy weight can indeed help to ebb or at least decrease the risk that you have of progressing the arthritis as fast. And so we touched on obesity. In addition, you want to continue your physical activity and healthy diet, and we'll go over kind of treatment of arthritis, which includes some of the same items. But even when you have either very mild arthritis or no arthritis, you want to keep your knees moving. You want to stay active. You want to if you work a desk job, you want to get up, walk around several times a day just to keep the knees active because that does strengthen the cartilage and the bone around the knee to help prevent those inflammatory issues. And things to avoid are intensive loading, so contact sports, high impact activities, things that can injure the knee, things that can ding the cartilage. And so in general, and I'm not, everything in within reason, but so in other words, running is okay up to like say 20 miles a week, and as long as it's kind of in a safe way. But once you start doing several marathons, like 2 marathons a year, then can be associated with increased risk of arthritis. And plyometrics, a lot of jumping off of a high area can damage the knee. So again, back to weight management, just to kind of go over a couple things about, while thinking about the preventing arthritis, preventing progression of arthritis, we also think about how do we, have better outcomes with surgery if that's what we decide to do. And so in this case, some BMI, which is the body mass index, over 40 to 45, and if you want to calculate your BMI, you can using an online BMI calculator. But if for the morbidly obese people, there is higher risk of surgical complications. So that means keeping the weight down, both to protect your knee and if you do ultimately decide like down the road, hey, I need surgery, so you need to start thinking about this early. Lowering your BMI can be very important, and doing it in a safe and sustained way versus having like big shifts in weight, which can result in malnutrition, which we'll go over in a second. And finally, if conventional weight loss fails, consider talking to your primary care doctor about a GLP-1 agonist, like you may have seen on TV or from a family member or friend. And these include things like Ozempic, Wegovy, Mounjaro. I don't have um, anything to disclose in terms of payment or anything. I'm just saying, these are things that are good to discuss, and these have actually been shown in big studies to decrease knee pain, regardless of regardless of losing weight. And so that is a kind of a very interesting and unique thing that I would recommend looking into if you're unable to keep that weight down. And gastric bypass surgery is another possible thing. You may have heard of a stomach sleeve or something like that. So just something else to consider. So in terms of other things to help, kind of both in the just keeping the knee healthy stage, as well as if you're preparing for surgery down the road, it's important to maintain good nutrition. The healing process begins before surgery. You want to tank up your nutrition levels. And so whether that is, and that's eating high protein diet, that's, making sure you have good vitamin D and calcium in your diet, and other, vitamins and minerals that are key to staying well nourished. But protein is definitely the best. And some people use protein shakes if they are vegetarian or if they just otherwise don't get enough protein in their diet. Chronic diseases, keeping those chronic diseases under control is also extremely important in both before surgery and just in general for knee health. And so that includes keeping that blood pressure under control, keeping the blood sugar under control. And in general, you want to have that A1C less than 7.5. And that can be pretty tough, but we do know, especially if you're considering surgery, that A1C over 7.5 can lead to increased surgical complications, but it can also lead to things like diabetic neuropathy, where your feet can get numb and tingly and painful. And so we just want to keep that under control. And then otherwise, stop smoking, vaping, using nicotine products those have been linked to knee pain and progression of arthritis. And also, tell your surgeon if you're on immunosuppressive medications, because they may need to be held before surgery. So now we're going to transition the talk into more of the treatment of arthritis, and it's going to range from non-operative, or excuse me, from the least invasive to the most invasive. And so this is the treatment pathway, and I'm going to talk about each of these areas, but again, they range from non-pharmacologic interventions to pharmacological interventions to surgical interventions. And I do want to just take 1 second to stop on that surgical intervention part on the right side of the slide. So historically, for degenerative meniscus tears, which is basically meniscus tears that happen um, that are associated with arthritis. Meniscectomy has been an option, and that what that is arthroscopy, a knee scope to clean up the knee, to remove the parts of the meniscus that are torn, to remove the parts of um, the remove the parts of the cartilage that are rough, and just kind of clean up the surface of the knee. But what we found with looking at thousands of patients is that that can actually accelerate the degenerative process and have people get to a total knee replacement sooner than if they didn't do that surgery, which is why it is now the recommendation of the American Academy of Orthopedic Surgeons not to do that in the for degenerative meniscus tears, which is different from an acute meniscus tear in a young person that may have happened due to a sport or injury or something. Another possible surgical intervention is high tibial osteotomy. That's to realign the tibia if it is bow-legged, or essentially. And that is an option for young patients. I'm not going to talk about it today, but really the workhorse for surgical treatment of knee arthritis is partial and total knee replacement, and that's what I'm going to focus on today once we get to that part of the discussion. So I mentioned the American Academy of Orthopedic Surgeons. They have a clinical practice guideline. That's a lot of orthopedic surgeons came together in one group to come up with consensus statements, meaning they all agreed that these are the best treatments for arthritis and of the knee specifically. And you can find this at the website at the bottom of the slide here. It's aaos.org/OAK3CPG. And it is a very good resource if you are interested in really digging into the weeds of the data, which I did not present every article here. So getting into the non-pharmacological interventions, the first step is just avoiding painful activities. So we call that activity modification. If you can avoid, if stairs always cause your knee to hurt and you can avoid them, then, try to just take that out of your life. Most of us have stairs in our homes and we can't do that. Walking aids can be very effective. That could include either a cane or a walker. And this can let you put less pressure on the knee that's affected. Cold therapy, in other words, icing the knee, can improve swelling and inflammation. Part of the RICE protocol: rest, ice, compression, elevation, and we'll go over the other ones as well. That can decrease that swelling and inflammation. Heat can help, but mainly just to loosen up the knee. If you have a stiff knee, you can use heat to loosen it up in the morning or before exercise, but mainly cold therapy is what you want to use. And that cold therapy you can do 20 minutes on, 20 minutes off is safe. For compression, you can use a compression sleeve that you can find at CVS or Walgreens or something, or a hinged knee brace to help offer a little bit more support with the metal slats on the side. And those can both, offer compression to reduce swelling, but also improve the stability of the knee and help it feel better. And then physical therapy or a home exercise program, both have been shown to be effective to improve your strength and stabilization of the knee. And um, that is because the muscles around the knee can stabilize it when the meniscus is not working properly. And then finally, low impact activity, such as walking, cycling, elliptical, or swimming. And yes, we can, include some, Pilates classes or a rowing machine or some other low impact activities in that arena. Can really help to prevent those flare-ups of knee pain while continuing to move the knees and prevent them from getting stiff and painful. Some other things that go along with that are neuromuscular training, and that can be basically balance training, making sure that you're able to balance as you get around your home, and weight loss, again, which I alluded to earlier. But every pound of extra weight is 4 extra pounds of weight through the knee when you're walking on stairs. So just bear that in mind, and at the very least, try to maintain your weight and not increase your weight. Going into the pharmacologic section here, so starting with the non-opioid pain relievers, the two most well known and for good reason are acetaminophen and NSAIDs. And so acetaminophen is like Tylenol. It does not affect inflammation, but it can be can be somewhat effective for pain relief. You can take up to 3 grams a day very safely, um, unless you have, very severe liver problems. But talk to your doctor about that if that's the case. NSAIDs are things like ibuprofen or naproxen, which are over the counter. That's like Advil and Motrin is ibuprofen, and Aleve is naproxen. Aspirin is also an NSAID that's over the counter, but that is a blood thinner, so I do not recommend that for pain control at all. That's really just to keep your blood thinner. And then finally, prescription versions of NSAIDs include things like diclofenac, which is Voltaren, meloxicam, which is Mobic, and Celebrex or celecoxib, which is Celebrex. These all are slightly different and have different pros and cons, and so you can talk to your doctor about that if you want to try it. The only thing with NSAIDs as a category is that they can cause harm to kidneys if taken for too long of a period consecutively, and they can also harm the stomach and potentially cause stomach bleeding if taken for a very long time or if sensitive to that. So as with, I'm going to mention a bunch of medications, but really, any medication decision should be discussed with your doctor. Opioids, like the ones you see here, are not a good treatment for arthritis. Okay, so at the bottom there, you see tramadol, codeine. These are weaker opioids. They can be addictive. They can cause dependence, and the worst of all with opioids, they actually increase your tolerance to pain, and therefore, excuse me, they don't they make the pain worse over time. Okay, and so you need more and more opioids to have more better pain relief, and also you become more sensitive to pain. And so that's why it's okay for a short time, especially after surgery, to use opioids for a very specific reason, but it is not a good treatment for any chronic pain. Creams are another option. Voltaren cream is the most commonly used and what I recommend. I mentioned before that Voltaren is diclofenac is the generic name, and it's an NSAID. But when you put it on your skin, it doesn't get absorbed through your whole system as much, and so it's much safer for people who have kidney issues or are taking blood thinners. And it can be very effective. The other creams, like you see here, there are lots of different versions that you may have seen on advertisements or at the pharmacy, and you can try any of them. Some, I have patients who kind of swear by any of them, but none of them have been shown, looking over a wide variety of patients to be, super effective compared to Voltaren. So this is a big slide, but a lot of injection options. The main one that I want to draw your attention to is number one. That's cortisone or corticosteroid, and that has a rapid onset. It can provide relief for a few weeks to 6 months, and it's for the whole spectrum of arthritis. It's covered by all insurance, and it's the most affordable, but it's also the one that has the best track record. And it is strongly recommended to try this by the American Academy of Orthopedic Surgeons. The other injections can be useful if you either can't take cortisone or cortisone didn't work for you. So number two here, hyaluronic acid or gel or visco, that causes inflammation initially, so it can get worse for a few days, but then it can give you relief for up to 6 months. I would not call it a silver bullet, but it can be a good option for some patients, and it's mainly for mild to moderate arthritis. It is usually covered by insurance, but it may need prior authorization if you have commercial insurance. So I don't see it get denied, but you may need to set up another appointment to get the shot if you ask for the shot at the initial appointment. The next one here, 3-PRP, which is platelet-rich plasma. Dr. Mark Bruner talked about this a little bit during his talk, and it is another very good option. Relief can last up to 6 months, but again, the data really only shows benefit for people with mild to moderate arthritis, and it's not usually covered by insurance, so it can be expensive. another option in the arsenal if if you'd like to try. And then finally, stem cells are very experimental still. There is some promising data, but there is no true evidence of benefit, especially compared to the other options here. There's definitely a lot more research needed, and I'm hopeful that maybe the next generation or perhaps the generation after that will have a good tried and true method to use stem cells. I personally haven't seen any great evidence for stem cells as they currently are in its current form. It's not covered by insurance and not widely available. So once you kind of go through all the other options, you tried altering your activities, you tried the physical therapy, you tried the injection, and these things aren't working. Or if you've just been suffering and you have severe arthritis, knee replacement is the best option for you, potentially. And so this is also called total knee arthroplasty. Arthro means joint, plasty means construction. So arthroplasty is essentially a joint replacement. And the this in arthroplasty we use implants to replace the damaged joint surfaces. They basically to resurface the knee. So the two main goals are to relieve pain and to restore mobility and function. And so, if you come to clinic to see me, I will ask you about how often, what's the severity and frequency of the pain, and what is your function, and what are your functional limitations, and we'll discuss, whether knee replacement could fix those issues. So there are two main kinds of knee replacement. There's partial knee replacement and total knee replacement. Uh, Starting with partial knee replacement, this is a good option if you just have arthritis in one part of the knee. And what it involves is removing arthritis from that one part of the knee. You see here in the tibia, the part of arthritis is being cut out, and on the femur side, the arthritis is being cut out, and it's replaced with these metal and plastic components. It is slightly less invasive than a total knee replacement, faster recovery, and it does feel more like a normal knee because we're keeping most of your ligaments. In fact, almost all of the ligaments are kept in a partial knee replacement. The only thing that is getting swapped out is the area of cartilage that is damaged for metal and plastic. But the one kind of caveat is that the partial knee, if your other parts of the knee develop arthritis, so in this case on the outside of the knee or the front part of the knee under the kneecap develop arthritis, then we may need to do a revision surgery to remove these implants and put in a total knee replacement at that point. And so it definitely is worth a discussion with your doctor. If you only have arthritis in one part of your knee and you otherwise are a good candidate, the benefits and risks of doing this. There are three kinds of partial knee replacement: medial, lateral, and patellofemoral. And the first two options are pretty self-explanatory. It's either the inside part or the outside part of the knee. The third part is basically if there's arthritis just underneath the kneecap, and that part can be replaced and leaving the weight-bearing part of the joint intact. I'm going to talk about total knee replacement now, and it's a great surgery. It's one of the best surgeries in orthopedics, and it has excellent outcomes. They're not perfect, but we'll talk about why in a second. So what a total knee replacement is it's removing the end of the knee that has cartilage on it and resurfacing it with a metal component on the femur, metal component over on the top of the tibia that goes into the tibia a little, and then a plastic piece in between them that so the new joint and articulation becomes metal on plastic. And this little clip here will show you the steps of a knee replacement. It's very quick. So you're lying down on the table during a knee replacement. The incision is made directly over the front of the knee. The parts of the knee of the femur that are arthritic are removed, as well as the top of the tibia. And bone cement is used in that area usually, sometimes without or sometimes with. And the components are cemented into place or impacted into place if it's press fit. The same thing is done under the kneecap to put a plastic button, usually, that if there's no arthritis there, that can be left. I know that was kind of a fast animation, but you can find all kinds of animations and surgery videos on YouTube if you'd like to get a little more information. These are X-rays of the knee replacements I discussed. On the left, you have the partial knee replacement, and on the right, the total knee replacement. And they are these ones are in good position. So people often come in asking about robotic surgery. Okay, so I just want to take a minute to talk about all the advancements in total knee replacement. And to dispel some myths, but also kind of enlighten you about what knee replacement is all about. So, in all types of knee replacement, the surgeon is still doing the surgery. There is no robotic system that in which the robot does the surgery for the surgeon, but it's essentially in all these different computer-assisted methods, the computer or robot helps to align the cuts of the femur so that they're perfect every time and there's no variation depending on your anatomy. So the types of computer-assisted surgery include computer navigation, which usually is a handheld gyroscopic system, and that can help you, and that really helps to make those cuts exactly in line with where you want. Robotic-assisted surgery, and this is an example on the bottom right here of what the feedback to the surgeon of where the implants sit during the surgery to plan appropriately and patient-specific instrumentation, which does require a preoperative CT. And I should mention that robotic-assisted surgery can require a preoperative CT in some systems, but sometimes the registration occurs during the surgery in the operating room. The patient-specific cutting blocks in all these situations, the robot or computer helps to guide where the surgeon is cutting. And so it helps you execute this personalized plan and makes the cuts more precise, and so that it just opens up the options a little bit more for the surgeon in terms of the fixation strategy, and so you don't have to go back and make edits to the cuts. It's right the first time. It helps to preserve healthy bone for that reason, and there are pros and cons to each of these methods. What I would say to my patients and to you is that you want to go with the system that the surgeon is most comfortable with and has had the most success with. A lot of surgeons value different things about each of these systems, and there is no evidence of better with or without computer, and so it's important to understand that, but also it is important to understand that these methods can really assist in making the surgery, the alignment of the surgery as perfect as possible. This is not me, but this is a picture of someone doing a robotic assisted knee replacement with a Mako robot. And again, I don't have any kickbacks or anything like that, but this specific robot has the surgeon holds the actual saw. Excuse me, the robot holds the saw while the surgeon is doing the sawing, but it guides the saw into position. There are other types of robotic instruments like burrs, or the robot places the cut block and the surgeon cuts through the cut block. And so there's a lot of different ways to do this. So how do you know when you're ready for the knee replacement? That's a question that is a very, very good one, and one that unfortunately I cannot answer for you, but I can help you kind of work your way through it and decide whether you are ready. And so you can make that decision. The main kind of guideposts I would say are if your knee pain and dysfunction affects you every day negatively, prevents you from doing activities that you enjoy or that you want to do, and if it prevents you from getting a good night's sleep. And it could be kind of one of these in a major way or all three of them in a minor way, but at some point, you may realize that it is not worth it to keep going and suffering, and it is time to get the surgery. There are some other things to consider here as well. So it's important to diagnose and treat knee arthritis early because or excuse me, to have the surgery earlier rather than later in some cases, especially if the bone is starting to wear down the bone, because that can make the surgery much more difficult, and it can also decrease your quality of life for an unnecessary extended period of time. The other thing to consider is that arthritis is degenerative, so it won't get better. If you have a flare up, that might get a little better, but the trajectory is it's going to keep getting worse. And finally, knee replacement overall has a 85 to 92% satisfaction rate. It's a little bit higher in our practice, but that means about 1 out of 10 people is not satisfied. But that means that 9 out of 10 are, and so that's our job to figure out who is going to be satisfied. And it tends to be people who have worse arthritis that are the ones who are more satisfied. But that's a good discussion to have with your surgeon. So let's talk about what the surgery looks like a little bit. So um, the first thing is you check into the hospital or surgery center. You usually need to be there about 2 hours beforehand or 3 hours. The knee replacement takes about an hour to an hour and a half, sometimes a little bit more if it's a little more of a complex knee that's more severe or more severe deformity or something. Physical after surgery, you wake up once your legs wake up, and you get up, you start walking, you do some stairs, and this has been a major change in the last 5 to 10 years. But having seen hundreds of patients, if not thousands, uh, stay overnight in the hospital 1, 2, 3 nights versus going home the same day, people are actually much happier going home. And I've talked to people about this a lot. Now, if there are reasons to consider staying overnight, and you kind of know yourself and what limitations you have. But the main ones are if you have, medical problems that need to be monitored. If you're advanced age, like your age is over the 80 is usually the threshold, but 85 some people use as a threshold. If you require an assisted device preoperatively, that means that you're using a walker or a cane all the time. Usually you're weaker and may not be able to get up right away and be independent right away at home. If you don't have help at home, that can complicate things as well, going home right away. And so it may be better to stay overnight. And then finally, if your pain after surgery, if your pain is not controlled or you're not able to urinate, those are other reasons to stay overnight. But I do about half my cases at the surgery center, which does not have the option of staying overnight, and half my cases at the hospital. And I'll tell you that not a single person up to this point has needed to stay at the surgery center overnight, which is usually not an option, or go to the hospital if that's needed. After you go home, the early rehabilitation, the first 2 weeks are pretty rough. Okay, the first 2 weeks is big surgery. Your knee is painful, it's swollen, it's stiff. But that's a limited amount of time. Okay, the in-home physical therapy visits twice a week, and they do basic things, initial measurements, stretching, light exercises. You're really not starting your strengthening training yet. And they also work on fall prevention and home safety. So they evaluate your home, make sure that you are not likely to fall, given your circumstances. Your focus at home is basically getting up to walk, ambulate at least 3 times a day, but generally, 5 minutes every hour is what I would recommend. You want to get that knee fully straight, fully in that straight position where it's flat. And it is very important to do that because in the operating room, we get you straight, but you need to be able to keep that straightness through the recovery period, and not give in to the temptation to let your knee bend when you're resting and then lose that terminal extension or that end of straightness that we talked about. You want to keep the knee elevated. Whoops, excuse me. You want to keep the knee elevated above the level of the heart when you're resting. Ice 20 minutes on, 20 minutes off, and then pain control is the mainstay of pain control is Tylenol and NSAIDs like Celebrex, if you're able to take NSAIDs for baseline pain control, and then opioids like oxycodone or tramadol just as needed on top of those baseline meds. Later rehab, just to kind of go very briefly through this, the phase two is getting comfortable. That's weeks 1 to 3. You're not doing too much strengthening yet. You're moving your knee. You're doing range of motion. You're starting outpatient physical therapy. At phase 3, that's weeks 4 to 6. Now you're starting to get a little bit more independent. You're able to start driving at week 4. You're able to do more things around the house, start cooking, start cleaning, start doing your activities of daily living. You're still doing physical therapy at that point, and then phase 4 is weeks 7 to 12, where you can really start strengthening and really pushing the envelope in terms of what you're doing. And you're able to walk longer periods. You're able to do more exercises, and you're able to even start some basic sports. And then after that, then you're resuming your daily activities. So, going over some frequent questions that I get in the clinic. As I mentioned, the knee replacement does hurt, but we have multimodal pain control, multiple different ways to control that pain, and early mobilization to keep you from getting too stiff, and you'll start moving right away. You'll put weight on it right away. So in terms of some kind of key moments in the recovery timeline, you return to work usually at about 4 weeks, but it can be sooner or later, depending on your work demands, and depending on when you're off of opioids. Some people or return to driving is at 4 weeks. Like I said, that's the recommended time. Although again, the key is that you're off of opioids, and after that, it is your discretion. And then you're fully recovered usually by 3 months is what I tell people. You're 80% of the way there by 3 months. So you're feeling very good most of the time. Some people are a little slower, some people a little faster, but I would say that you're recovering all the way up to a year. But most of the recovery happens in the first 3 months. Activity restrictions don't include any specifically, but do understand that this is metal on plastic bearing surface. The plastic can wear out or dent if you are very, too aggressive. And so, just I don't want you to limit your activities necessarily, but just understand that there are risks associated with doing a lot of running on a knee, for instance, and a lot of high impact activity. And so it'll last for, in 95% of patients, it lasts for 10 years. And over 85% of patients last for over 20 years. So you can see that the reoperation rate, or the rate of needing another surgery on the knee, is low. To summarize, we went over a lot this talk, but the most common cause of knee pain, especially in people over the age of 40, is arthritis, especially osteoarthritis. It's degenerative, so it generally goes down over time, gets worse, not better. And it's important to get early diagnosis and treatment. There are lots of different options for treatment. Okay, so you're not going to come to clinic and be signed up for surgery right away unless these other options have failed. Okay, or if you've been suffering for a long time with this problem. And then finally, knee replacement has an excellent satisfaction rate. And at OrthoBethesda and Aligned Orthopedic Partners, we will help you through this every step of the way. To give you a little bit, this is kind of the final slide, but if you want to read more from the patient perspective about about knee replacement, go to hipkneeinfo.org. You see the website at the top, and there is abundant information for you to read about knee pain, and then knee surgery, and get more information there. Again, this is me, Carey Politzer, and my information is at the bottom of the screen. So at this point, I'm going to open up the chat and take a look at some questions. And I'm going to try to steer clear of kind of the very specific ones, but I'll answer in a more kind of broad way. And we have about 10 minutes for questions, so I'll try to go through some of these pretty quickly, okay? So we do, like I said, we do offer gel injections. For people who have Medicare, we can usually do it on the same day. We can do a gel injection on the same day as you're there, because that does not require prior authorization. But if you have commercial insurance, It just means you can either call or you let our office know ahead of time, and we can get that set up for you, before your appointment. So just if you let us know ahead of time, we can do that. Um, So after total knee replacement, there can be clicking. There can be crepitus, which is basically the knee feeling like it is kind of like a rubbing sensation where it's crackling, kind of crackling. That's usually from scar tissue, okay? And the when that happens, if it usually it's not it's hard to fix without another surgery, but most of the time that does get better over time, not always. So if that is, if those things are really bothering you by over a year out when the scar tissue is fully matured, you can come talk to one of us about it, and we can tell you about how to form a plan going forward. So someone asked about platelet-rich plasma. That we have a very good success rate with platelet-rich plasma for knees that have mild to moderate arthritis. So if you have bone-on-bone arthritis or very severe arthritis, where it's close to bone-on-bone, that is not going to be a good option for you. But if you are interested in platelet-rich plasma, Mark Gruner, Gruner, is your guy, and he can do that injection for you, or he can talk to you about that injection, I should say. The So yes, arthritic knees can definitely affect your back. If anything with your gait is off, if you're limping, then you're relying a lot more on your back to keep you straight. And so that can definitely make your back, that can hurt your back, that can cause pain in the back, that can also cause pain going down the legs called sciatica and other issues. And so sometimes getting a knee replacement can actually help the back pain. It's a little more common for like a hip replacement to help with back pain if you have both hip and knee problem or hip and back problems. But certainly knee replacement can help with back pain. And generally speaking, biking for longer than 2 to 5 miles is okay. But so I was kind of referring to like running. You probably don't want to run more than about 5 miles to 5 to 10 miles at a time to help prevent too much wear and tear and too much arthritis on the knee. But if you unless you're very you have a lot of training and are equipped to do that. Biking, it kind of depends on the person, but you probably don't want to go over, say, 20 miles. And if you're not used to biking a lot, then stick to starting with 2 to 5 miles. So I'm just reading through a couple of these. Some of them are pretty personal. This one asks, is it beneficial to take care of an arthritic knee earlier or let it keep going until it's always painful? That's a great question. I think it's worth definitely getting it looked at, getting an X-ray, seeing where your knee is at, and potentially getting an injection or talking about things that you can do to stave off the knee replacement. Because sometimes people come to me with a painful knee, and I give an injection, and we do physical therapy and some of these other options, and they don't come back with knee pain for another year or two or more. So understand that just because it's painful now. But if it's a very short amount of time, that it doesn't always, progress really rapidly. But sometimes if it's very really painful now, sometimes that pain doesn't go away. And so that's where it's important to talk to your, doctor or orthopedic surgeon about trying some things that aren't surgery, and then if those fail, then getting surgery. Yeah, so someone asked to clarify what I said about partial meniscectomy, which is the knee scope. And what studies have shown is that looking at a lot of people, this is obvious. This doesn't necessarily mean to any one person, but looking at over the whole, people who undergo partial meniscectomy or knee scope for a cleanup end up requiring a total knee replacement up to a year before people who don't undergo that surgery. And so generally speaking, if you have pain due to degenerative meniscus tears, we don't recommend doing surgery for that. And that is a recommendation from the American Academy of Orthopedic Surgeons. Um, Someone asked how long do knee replacements last, and so by 20 years, the survivorship, meaning the percent of patients who still have the same knee replacement that they had put in without any further surgery, is 85%. So that means about 15% of patients who undergo knee replacement may need a surgery within 20 years. Another surgery, that's 15% may need another surgery within 20 years. But that means that over 85% don't need another surgery within 20 years. And that number, is basically 1 to 2% a year after that who need another surgery. Some of these are a little bit too specific. Well, give me a second. So someone asked about insurance limitations and considerations for computer-assisted surgery versus traditional. That is very rare for an insurance company to deny the computer-assisted part of the surgery. But I have seen it. Uh, so it can be worth a discussion between the surgeon and the insurance company to kind of iron that out. The reality is that I believe all my partners, in fact, I know that for a fact that all my partners and I know and do an excellent traditional knee without robotic and computer assistance. So if that happens, you're still in amazing hands. But some that does happen, maybe 1 out of 100 or less. X-ray of the knee is critical to understanding whether the knee is arthritic, and it also is critical um, to tracking the knee over time to determine how fast the arthritis is progressing. And in fact, a knee X-ray is I would say is more valuable than a knee MRI in terms of arthritis, because it shows us a lot more kind of a lot more of an overview. It shows us like the book cover of what's wrong with the knee. The knee MRI can be useful if the knee X-ray does not show severe arthritis, but you're having severe pain. We can get potentially get an MRI to look closer at that to figure that out. Um, but it is critical. All right, a little bit specific. Let's see. Someone asked if squats are bad for knee arthritis. They are not bad for knee arthritis, but I would tell you that you want to do low weight, high rep to increase the muscle tone in your thighs. And so when there might be instability of the knee, you need to it's very good to work on quad strength and work on your knee strength. And so quads or squats are a great way to do that, as long as you're not too painful. Sometimes when there's a lot of arthritis underneath the kneecap, that can become very painful to do squats, and maybe it's not the best in those cases. Someone asked about Someone asked about a like a nerve block. So there are alternative treatments to arthritis to decrease the pain in the knee for people who are not good surgical candidates. So that one of those treatments includes geniculate artery embolization, GAE, and the other one is kind of a nerve ablation. That means just um, removing the nerve that goes to the sensation in the knee, and both of them have varying results. They're not great. They're not great for most people, but for people who don't have are not able to get the surgery for whatever reason, and want to try that, the pain specialist can help with that. cortisone injection frequency. So cortisone injections can be given up to once every 3 months. It's also worth noting that if you do get a cortisone injection, you have to wait at least 3 months until surgery because it does decrease the inflammatory response in the knee. And we need that in order to fight off infection and make sure your surgery doesn't get infection. And so that is why you need to wait at least 3 months. All right. How are we doing on time? I think we're just about out of time. I'm sorry for the people who I didn't get to your questions, but please come visit and we can discuss your very specific situations in clinic. I'd be happy to go over that with you anytime. You can see my email is here, and or you can access my medical assistant and also my hip and knee replacement scheduler on this website that's listed here.
We will be sending out all this information, including the video recording with the links, and there is another link for more lectures like this coming up for the rest of the year. Thank you guys so much for joining us. I hope you found this very informative, and thank you to Dr. Politzer for all of this information. I definitely learned a lot myself. I hope everybody had a great rest of your day, and thank you again for joining us. Bye, everybody.
Take care.